And for next talk, I'm inviting Dr. Lo Lili, and she'll be speaking on management of aspergillosis. And she has been introduced in the morning session.
Okay, good afternoon again. So we're moving from the topic of yeast now to the more exotic molds. So I'm speaking on this management of aspergillosis. Aspergillosis is one of the commonest mold that could see in our isolates. Now, the name of Aspergillus actually came from a priest, right? He is also a biologist. So he found it and he named it after the aspergillum, which is a sprinkler of water, holy water. So if you're a Christian, you're probably more familiar with this. So now, the risk factors for invasive aspergillosis, if you look on the table, there's a newsletter, page number 2, is well listed, illustrated the risk factors of invasive fungal infections. Okay, so profound and prolonged neutropenia, not only neutropenia. And there's on your right is a very old study, aged about 35 years ago. It's found that the incidence or the rates of developing fungal infections increase day by day. So initial period is 1%. If it's more than 21 days after the third week, increase by 4% per day. Okay. So what is the commonest site if a patient were to get invasive aspergillosis? Based on most of the study, it's found that lower respiratory tract is a commonest site, mainly pulmonary infections. Some centers actually also found that, there are some patients that develop sinusitis, that what Dr. Tan has just shared with you, need always have to ask whether there's any facial pain. So in one of the study, I think done in the Professor Chin's center, so in the 15-year study, they found that the incidence of fungal sinusitis is about 1.7%. And in this study, the commonest mold is actually Aspergillus, followed by mucor. Okay? So occasionally, this invasive aspergillosis might spread hematogenously to other organs, for example, the liver, brain, and skin. So the symptoms, okay, Dr. Tan also have touched on it, is not very pathognomonic. You can't differentiate it from bacterial infections, mainly fever, unresolved fever, cough, a bit of dyspnea, and chest pain. Okay, it's not very helpful, but those neutropenic patients, if they do not respond to antibiotic, if they develop all these features, always X-ray and get the CT scan urgent. So I'll follow with a case scenario. And this case, it was a very old case done. We've seen this patient many, many years back when the hematological service was just started in my hospital. A 45-year-old gentleman who is a farmer, okay, came to us complaining of fever, lethargy, and easy breathing, 1 to 2 weeks durations. And this was the white cell count, pancytopenic. Okay, so PBF consistent with acute leukemia with 51% of blood cell. So we went to him and sit down and talk to him, explain to him you need the bone marrow examinations, and from there we acquire more information and tell you which chemotherapy that would recommend for you. The moment he heard about cancer, okay, the next thing is he asked for discharge immediately against the medical advice. Okay, so he went back. Okay, after even though we described to him, we told him that the risk of him getting infection, he might die because of the cancer. So again, he still refused treatment. We saw him 1 or twice in the clinic. He refused for admission, but surprisingly, 7 months later, he came back. Okay, we thought he would die, but he came back 7 months later. Okay, complaining of fever and lethargy, and this was the white cell count on the presentation 7 months later, a bit of leukocytosis 43,000, normal liver function test and RP, and finally he agreed for bone marrow examinations, and we did the bone marrow with immunophenotyping. It was confirmed to have precursor B-cell ALL. Okay, but after we told him the diagnosis again, he said, no, I agreed for bone marrow. I didn't say that I want chemotherapy. So again, he asked for discharged. So what our postulation may not be true. We believe that he probably seeking some traditional therapy. He just came to us, want us to tell him that, after taking the traditional treatment, he has been cured for the disease. Unfortunately, we disappoint him. So the disease is still there. So he came back to us a month later complaining of worsening of symptoms, lethargy, okay, and mainly because anemia and also low-grade temperature. Therefore, this time around, he requests for chemotherapy. He couldn't bear the symptoms anymore. So before chemotherapy, this was the counts, okay? White cell count 48,000, HB 4.3, given some blood transfusion, and platelet of 5, and the standard chemotherapy according to the regime for ALL given. And he was chemo naive that time, never been exposed to any chemotherapy, but the hematologist started him on ciprofloxacin and fluconazole as prophylaxis. On day 3 after chemo, ALT increased to over 10 times of the upper normal limit. To our surprise, it's only after day 3. And we stopped the fluconazole. Eventually, we had to stop the ciprofloxacin as well. Eventually, the ALT peaked at day 5 to 2,000 over, okay, accompanied by the bilirubin, which was 168. Investigation of viral hepatitis were all negative. So the sudden increase of the transaminitis may be due to drug, maybe due to chemotherapy, or we suspect that could have taken something else at home, the traditional treatment. So this was, in the box was the progressions of the liver functions. So subsequent chemotherapy has to be delayed, and even when they give a tiny little dose of chemotherapy, we have to be adjusted because of these liver conditions. So at neutropenic, at day 7 of chemotherapy, almost nadir count, he developed fever, persistent, despite that broad spectrum antibiotic was given to him. What you name it, he had received piptazo, aminoglycoside, carbapenem, and blood culture were persistently negative. So vital signs remained stable. There were no skin lesions. On auscultation to the lungs, there was slightly reduced entry of the left lower zone. So subsequently, he complained of a little bit of cough. We know that that is not a good sign when you start coughing, okay? But there was no hemoptysis. So this was a count, the white cell count, okay? Of course, Neupogen was given in between. So day 10 was the nadir, the lowest white cell count. Eventually, it slowly picked up. And you look at ALT, it slowly come down. So at this point, it's a neutropenic fever, not responsive to antibiotics. So we must think of invasive fungal infections. So we quickly send off the galactomannan, scheduled for CT thorax. And that point in time, it's not easy for us to get a CT. If you have a neutropenic patient, you ask for CT, they'll give you a date. Okay, nowadays different. Nowadays, as Dr. Tan mentioned, you almost get it immediately if we just tell them neutropenic fever patients. Okay, so while waiting for the CT thorax, so which antifungal agent would you consider to put him on, knowing that he has been on prophylaxis, non-mold active agent, the fluconazole? Okay, in view of the high ALT, it was reached until few thousand. So we think that, Azole is our option because that is the most hepatotoxic drug. Therefore, antifungal was chosen at that time because of his liver conditions. So this is a summary of the conditions of this patient. And clearly, this patient from high-risk group, prolonged and profound neutropenia, fever not responding to antibiotics. And of course, while waiting for all the workups, CT thorax, biomarkers, culture, and HPE, and we need to start him on some empirical antifungal agent, and which choice, it really depends on whether this patient has been exposed to antifungal agent. If it's true, then is it a breakthrough infections or just because of the TDM is inadequate? And chest radiograph, chest x-ray is useless in this situation because it's not able to pick up fungal infections at the early stage. Even though they picked up, also is not helpful in terms of differentiating between fungal and bacterial infections. So this was the x-ray taken when he was a bit more deep sleep. Okay, it's not a normal x-ray. In fact, it's quite horrible. Okay. And galactomannan turned out to be positive more than 0.5, the optical density index. But fungal culture obviously is negative. Okay. CT thorax finally done, but when it was done, you look at the white count, the summary of the white count is almost at the coalescent phase, meaning that the white count already recovered. This is a bit too late, isn't it? So we want the CT to be done at the juncture when patients started to have fever and chest symptoms. So this is the X-ray. So I don't think at this point in time, we can get any more beautiful X-ray of CT thorax changes as these patients because we do CT now fairly early. So the scan on the left side, you can see a lot of small nodules along the pulmonary vessel. And on your right, there's one lesion with a cavity. And there you see that there's a very obvious big cavitating lesions there. Okay, and also on the left, there's a mass at the hilar area. So I thought this is a very pathognomonic or very classical descriptions of fungal infections as what described in the textbook. So we don't see this nowadays because we are too fast. Okay. So the finding of invasive pulmonary aspergillosis is what described in the book there. So it started off with a lung nodules, which it means that it's a necrotic area that containing the fungal infections, which is surrounded by the halo or ground glass area, meaning that there is a hemorrhagic infarctions. Okay, there's an early sign. All right, even though it's not pathognomonic, but if you see these pictures, this finding in a CT thorax, it must highly suggestive of fungal infection and start the workout. But unfortunately, the halo sign only lasts for 10 days, it's transient. After that, it become the confluent consolidations. Okay, you may see some hypodense sign. Okay, and all these eventually progress into cavitations when the lungs start to retract, leaving behind a cavity. Okay, so cavitations or air crescent sign is a late sign, meaning usually happens when the white count started to recover. And we do not wish to pick up only at late stage. It should be picked up at a very early phase whereby you have already initiated antifungal agent. Now, in view that these patients, the symptoms progress despite on antifungal fungin, what to do now? Is it a clinical failure? Would you consider to start on another antifungal agent as for combination fungal therapy? Okay, so ALT gradually improved, okay, but it's still taken a longer time. It's hovering around 500 to 700. Okay, at day 24, we commenced on the amphotericin B because we think that antifungal fungin is not working. So it was on combination therapy for a while as well. We'll slowly increase the amphotericin B from 0.5 titrate up to 0.7. So we still use a fair bit of deoxycholate amphotericin B because the liposomal is just far too expensive. So liposomal we only keep for those patients that really could not tolerate deoxycholate amphotericin B. So the choice of antifungal agents is a tricky question, isn't it? Sometimes it's easy to say, okay, we can list out all the antifungal available. So actual situation in reality is quite difficult as for these patients I presented to you. So on 28 days, okay, so this patient become less arousable. Okay, every day he was fighting with us. I want to go home. I want to go. One fine day when I see him, stop talking to us, stop fighting to us. So it's not good. Become less arousable and later followed with the brief seizures. So we did a CT brain. CT brain shows that there's multiple hypodensity in the brain, which is probably consistent with disseminated septic emboli, meaning the fungus probably already showered to the brain area. So clearly, antifungal fungin is not a good choice because it doesn't penetrate into the CNS area. But amphotericin should be able to cover the brain area, but we have to titrate to the optimal dose. So fortunately, this patient able to tolerate the deoxycholate amphotericin B, we able to increase the dose to 1 milligram per kg per day. As the ALT slowly improve, okay, we add on voriconazole. Eventually, we off the amphotericin B. So his clinical conditions continue to improve. As the white cell improved, he also improved. Eventually, he went home and he refused further chemotherapy. Eventually, he died because of the leukemia. Okay, that's a sad story just to show you the event and also the antifungal agent. Now, for this case, we only have CT thorax and also the galactomannan to guide us with the diagnosis. In fact, I only have one galactomannan. We didn't repeat the second one because we thought that the CT is quite classical. So most of the time, we could not get the positive blood cultures for Aspergillus. Even if positive, also it will be a delay before you can diagnose because it will take a few days before you can grow. So sometimes you may grow the Aspergillus from tissue biopsy or from respiratory specimen, for example, a BAL or sputums. And if it were to be grown from the sputums, you have to take it seriously because most of the time it is the significant, especially in the patients whereby they're immunocompromised and also with respiratory symptoms. Okay, the picture on the right is not belonging to this patient. It's belonging to another patient of mine who is taken from the BAL culture. Okay, so the microbiologist was so excited they rang us when they grew this. Say, come quickly to the lab. We have something to show you because it's been a long time they didn't manage to grow anything. Okay, now of course histopathological examination is crucial, but most of the time, because the hematological patients, they are thrombocytopenic, we can proceed with the invasive procedures, unless it's a simple skin biopsy. So we have to rely on now non-culture method, okay, rapid diagnosis of invasive aspergillosis. So we have serum galactomannan, which is more specific, although it will be positive in other fungals, for example, Fusarium. Beta-D-glucan, non-specific, and some center you may be able to perform Aspergillus PCR or the DNA PCR. So I won't go into this because there will be another sessions on the serum galactomannan later on. Now, galactomannan itself maybe is not good enough. So if you combine two biomarkers together, either in the serum or BAL, will increase the sensitivity in diagnosing invasive aspergillosis. And you look at the table down there. So when you combine two together, galactomannan together with the PCR, the positive predictive value has increased above 90%. Okay? So this is another study whereby they combine, this is a pan-fungal PCR. Okay, when you combine pan-fungal PCR with galactomannan or pan-fungal PCR with CT scan, okay, they have a better performance, increased sensitivity, and the negative predictive value is excellent, more than 90%. So in conclusions, okay, you may use the biomarkers, combination of biomarkers as a tool in your antifungal stewardships. Okay, I think we have mentioned this term many times. In fact, last month we have just celebrated the World Antibiotic Awareness Week. I think we should change the term into Antimicrobial Awareness Week, whereby people should be alert about antifungals resistant issue as well. So if you can afford, you should have galactomannan and another form of biomarkers. Okay, if these two tests were negative and your CT shows that there's not very suggestive of fungal patients, you may safely opt the empirical antifungal agents. Okay, so if your hospital is very much into antimicrobial stewardship, that is the time you bring in all these biomarkers and even your procalcitonin. Now, common pathogens, Aspergillosis, there are many species. Some of it is not pathogenic. Commonly, it's still Aspergillus fumigatus, okay, followed by Aspergillus flavus and nigers. Now, it's important to identify the Aspergillus until the species level if you're able to culture it, because some of the Aspergillus, they are intrinsically resistant to certain antifungal agents. For example, Aspergillus terreus is usually resistant to amphotericin B, as well as Aspergillus nidulans, which is usually found to be resistant to amphotericin B. Susceptibility to antifungal agents. Not all centers will carry the susceptibility test of Aspergillus. It's not routinely done. Even done, also sometimes it's only for surveillance purpose. But based on the Dutch study, the Netherlands, they found that actually the resistance of Aspergillus fumigatus had increased twofold comparing from 2014 to 2017. As I think Prof. Chakrabarti mentioned earlier in his introductions talk just now. So it probably is in the environment, and this is a map showing the resistant Aspergillus fumigatus. So it's postulated that probably the Aspergillus fumigatus acquired the resistance from the environment because of fungicides that used in the farming. Okay, it has some activity against these Aspergillus fumigatus. So human being, maybe because we inhale the spores, therefore we acquire the resistant type of Aspergillus fumigatus. So, but it's not so common in this part of the world. Now, if we can't culture it, how do we know that it's a resistant gene? We can't do sensitivity tests if we're not able to culture it. So scientists have developed test kit, the PCR test kit, that's only to detect the resistant gene in this Aspergillus species, okay? But it's not perfect because it's only able to detect 2 genes out of the plenty, many genes that are available that confer to the resistance. And one is resistant to an azole, it might cross-react and cross-resistant to other azoles, okay? For example, if the isolate is resistant to voriconazole, it has high MIC towards the new azole as a voriconazole as well. So it's bad news. One is resistant, it probably the whole band of your azoles treatment all not working. Now, when you consider combinations therapy or antifungal agents, if you have your surveillance data and you can prove that your Aspergillus fumigatus, the resistant baseline is more than 10%, yes. So when you encounter patients that need treatment for mold, maybe you have to consider antifungal combination therapy. Okay, alternative option will be azole plus echinocandins or amphotericin B. So salvage therapy meaning that when the patient shows inadequate response to the antifungal agents that as according to the recommendations, so you might consider second line or even combination therapy. So isobuconazole, okay, European guideline has put up isobuconazole as a first-line treatment for aspergillosis together as with the voriconazole, because based on the study, it shows that voriconazole as well as isobuconazole, they are non-inferior in the treatment of invasive aspergillosis, whereby in the IDSA, the American, they still put isobuconazole as an alternative to voriconazole. So these are the list of the antifungal agents that has activity against aspergillosis. As I mentioned, it's good to know, but sometimes in clinical practice, it's very difficult to choose which antifungal agents that suitable for your patients, especially you have all in the list. So most of the time now, people move to voriconazole, but mind you, you need TDM monitoring. It's important to check the TDM to ensure that patients achieve the good therapeutic level, but yet do not develop toxicity. So recently, I just have a patient, hematological patient, who was put on voriconazole because suspected to have a fungal sinusitis. So after a few days on voriconazole, out of the blue, she's a Malay, parents are Malay. So out of the blue, she's able to speak Thai language, Siamese language. Then probably Miti and Dr. Arya will understand. So never in entire life that she had learned Thai language. So we off the voriconazole, okay, immediately the symptom disappeared. We wanted to send for the TDM, but unfortunately it was a long weekend. Some errors happened, so we missed the specimen. So she made us to promise her that do not put her on the medicine that can change her center of talking. She worried that she'll speak alien language again in future. So this is to illustrate that the importance of carrying out TDM monitoring when you're using certain antifungal agents, for example, voriconazole, okay, posaconazole, itraconazole. Okay, so if resource limited, you can't have access to voriconazole, the next in line will be amphotericin B, okay, either liposomal or deoxycholate. Posaconazole, most of the country, they do not have access to the intravenous form. We only have the tablet, the delayed release form. Itraconazole, not a popular drug right now because of poor bioavailability, unless you can have the new formulations that mentioned by Dr. Atul just now. Echinocandins mostly used in salvage conditions. Okay, or like this patient because of the liver enzyme, liver problem, therefore we have no other option but choosing this. So salvage therapy, there are many combinations, okay? Most data combine echinocandins and voriconazole. You can also combine echinocandins and amphotericin B. So this is my last slide. So Aspergillus also can affect the birds, the poultry. So they also may have cough and also shortness of breath, and you biopsy the lung. That's how it looks like in the autopsy findings. That's my last slide. Thank you.